Hello and welcome to the case study review on Parkinson's disease. We were provided a case related to Amy and we wanted to review over that case in the realm of different questions that have a better appreciation of how difficult it is to isolate the beginning of Parkinson's, how there can be other factors that come into play, and really to isolate the influence of this condition. And when it begins, you have to have a pretty broad view and appreciate the history with some of the different variables that come into play over the course of time. So through answering the questions of the case, we're going to have a better sense of that. Now to begin, question number 1. What health conditions were present prior to the start of the scenario, i.e. above the clinical horizon? So you would have the opportunity to put a P onto the graph that would be there just to help organize your thoughts. Now, in terms of what is meant by clinical horizon, when a condition is subclinical, it has no recognizable clinical findings. But once past the clinical horizon, it is a distinct clinical condition, which has signs and symptoms that can be recognized. So we're discussing things that were there prior to the start of Parkinson's being part of the scenario. So some things would include the asthma that she's had since the age of 50, and the left knee osteoarthritis that has been there since the age of 55. Affiliated would be conditions that are there around for a shorter period of time, like the low back pain, as well as right hip pain that she had in October of 2005. Question number 2. Which conditions seem to be stable? Well, a stable or a medically stable condition, it indicates that the patient's disease process has not changed abruptly or significantly. So how it presents, although there might be mild fluctuations, is pretty consistent in how it is. The asthma, as well as the left knee osteoarthritis, would both be in this category, but there's a caveat to that. The left knee osteoarthritis changed in April 2006. Up until then, you could argue it was stable. With the affiliated increase in pain, it was such that for Amy, she had to undergo surgery, a total knee arthroplasty or total knee replacement, in December of 2006. Prior to that, we could argue that the left knee osteoarthritis presentation was stable for an extended period of time, and the asthma is an ongoing feature. Indicate when Parkinson's disease rose above the clinical horizon and indicate the time periods it stayed above this horizon. Well, Christmas in 2007, her daughter first noticed and was concerned that Amy was walking slowly, even 1 year after surgery. And Amy seemed to have difficulty picking up her feet when walking and still leans forward even though her knee pain has been resolved. So it's probably at this point we would suggest that there is the presentation of Parkinson's disease, in that we have an altered gait pattern, a slow gait pattern, a difficulty in lifting the feet prior to a diagnosis, and we can appreciate no other underlying reason for this medically. Now, keep in mind that the second half of the question, indicating the time period it stayed above this horizon, Parkinson's disease is neurodegenerative. So the time period that it stays above the horizon, i.e. there are going to be some symptoms present, and finding it is a distinct clinical condition which has those signs and symptoms, it would likely stay that way till the present day. It's not going to rectify. There's other clinical conditions, for example, rheumatoid arthritis, where in the early stages, the person may have a flare-up of inflammation and it's there for a period of time and then it rectifies. And there's no underlying degeneration or other clinical presentations of it. So it goes above the horizon and then it goes below the horizon. It flares up and then settles down. Parkinson's isn't like that. It's neurodegenerative, and where there was no discussion in the case giving us the impression that the gait that was found in 2007, which is slow, has improved or changed, we would anticipate that it rose above the clinical horizon in Christmas 2007 with the first identification really of there being an altered gait with no reasoning why, and it would stay that way up until the present day. Question number 4. Which health conditions seem to be acute, meaning a short-term flare-up, that had some level of resolution during the timelines of the scenario? Well, that would be the low back pain acutely found and right hip pain in October 2005, and resolution over the course of 2 months. Fortunately, the low back pain wasn't chronic, and the right hip pain didn't go on for a long period of time. These short acute flare-ups still may be relevant for a patient. Again, when discussing Parkinson's, you'll want to be aware of all possible aspects of the medical history. So you'll want to know not only what conditions are ongoing, but even previous injuries that seem to have rectified, just to ensure that they may not have also some impact on the patient's current medical status. Question number 5. Indicate the subclinical phase of Parkinson's disease in this case, and that is more straightforward. That's going to be prior to Christmas 2007. So anything prior to that point in time, we would put down as a more subclinical phase. There may be periods of time prior to this that there were clinical findings. But again, this is the first we have in the case of anything that highlights or gives us a suspicion that there is a Parkinson's presentation based on Amy's walk. So as best as we can tell, everything prior to Christmas 2007, we would deem as that subclinical phase. Question number 6. Which time period might the acute flare-ups have overshadowed the subclinical phase of Parkinson's disease? What health condition or conditions may have been involved? And this is getting into a little bit more of the trickiness of identification or diagnosis of Parkinson's. Leading from the previous slide in terms of we feel fairly confident saying Christmas 2007 is where we can first identify that there is something going on. We have to acknowledge that in April of 2006, this might be a period of time where we had our acute flare-up. Amy was noticing that she was having increased left knee pain with minimal relief from medication. And it was to an extent where, yes, this involves the osteoarthritis of her left knee. And yes, this is significant enough that the left knee condition would require follow-up with an orthopedic surgeon, who in turn feels that a surgical intervention, total knee replacement, would be appropriate. But the tricky thing is we have to also appreciate that if you have left knee pain due to the osteoarthritis, it will likely affect your walk. Also, one of the first signs of Parkinson's for Amy was an affected walk. So with that in mind, this acute flare-up of left knee pain, what used to be a stable condition, and now increasing left knee pain to the extent where other injections, other interventions are ineffective, you need to have surgery. This will affect your walk, but it may also overshadow the subclinical phase of Parkinson's disease, and maybe where we feel the subclinical phase starts in 2007, actually maybe it started a little bit earlier, possibly earlier that year or even in 2006, but we would have difficulty isolating that because Amy had a left knee osteoarthritis presentation that required investigation and later surgical management, and you would have to recover from that surgery, which takes time. So the actual period where Parkinson's might affect her gait, it's harder to identify. Finally, question 7. What functional activity was a common theme in the potential overshadowing of Parkinson's disease by other health conditions? The patient's gait. So in 2006, there was increased left knee pain with osteoarthritis. And in 2007, Amy was having difficulty picking up her feet when walking and still leans forward even though her knee pain has been resolved. So the common theme that can get in the way of things is the patient's gait and the difficulty in isolating whether it is related to Parkinson's or more so, well, no, in April 2006, we have a flare-up of the left knee, so if you're walking slowly or having difficulty in lifting your legs a bit, you're probably compensating for your left knee pain. It's an orthopedic condition. And then when the orthopedic condition is addressed and rectified, well, then it becomes more of a neurologic issue. Let's keep in mind that a tremor, which is, as we learned in the presentation on Parkinson's, one of the common reasons why someone will seek out medical assessment, and in Amy's case as well, because she did not follow up with her physician until this tremor began. That began somewhere in July of 2008, and that would be after some of the noted gait issues that were present in Christmas of 2007.